I think we are in fascinating times, and some say that the role of surgery will diminish. I don't think this will be the case because we will still operate on smaller lesions. I think the preference is still to go for surgical resection, not only to completely remove the tumor, but then you can perform a detailed pathological and also molecular genetic analysis to see what is inside the tumor, whether there are targetable mutations or not immediately, but for the future of the patient when the tumor recurs, that we have enough material to do a molecular genetic analysis. So I think with screening that's going on now in Europe and the rest of the world, we will be confronted with more and more smaller lesions. And also for the largest lesions, if I realize what we can really obtain now with induction chemo, and especially induction chemoimmunotherapy, with major pathological responses up to 50-60% of the patients, I think the indications for surgery will even increase in the near future. And of course, we are confronted with more and more technical difficulties after induction therapy. So you don't have any clean planes anymore after chemo or chemoimmunotherapy. So at that time, it makes it more difficult for the surgeon. So on the one hand, I think the indications will increase. But on the other hand, we have especially teach the younger residents because they will be confronted with more technical difficulties, especially around the hilum and the pulmonary artery. And I can assure you that sometimes, especially after prolonged induction chemoimmunotherapy, those adhesions that occur can be very difficult to dissect.